So thanks everybody for coming out tonight. So my role actually is I'm the medical director for the Halton Geriatric Mental Health Outreach Program, which is an outreach program specifically for seniors with all sorts of mental health issues. And we actually do outreach visits to homes, nursing homes, retirement homes, to see seniors, because a lot of seniors, and just for other reasons, find it very difficult to make their way to kind of your traditional clinics and doctor's offices. So that's kind of where I stand. I'm also an assistant clinical professor from McMaster University, so we also have learners, senior medical students, residents, fellows who come through. So some of you may see me or one of my colleagues come by, and we may have students in tow, so that's kind of why there's sometimes a lot of us around. So contrary to kind of what was advertised, I don't walk on water, but I do try to keep myself up to date as much as I can given my other responsibilities. So I think that it's great that the family, you as caregivers and family members are here to kind of hear about dementia, and this program, Acclaim Health, is a very good support through both the day programs and the other services it provides for its clients and for caregivers. So I think that you're all doing a great thing by trying to learn more about the disease, because the whole issue is trying to plan ahead and try to see what the next steps are once you get there, because I can certainly tell you that the medical system does not react very well to urgent or even emergent or even urgent situations. So I think pre-planning is really key, and in order to do that, you have to have the information. So the objectives tonight is really to kind of provide the layperson with just some fundamental basic knowledge about Alzheimer's dementia and just the different types of dementia. It's not an over-inclusive, highly scientific review of the literature or anything like that. It's basically kind of information to help kind of the layperson understand a little bit more about the biology of Alzheimer's disease. So what we're going to be doing tonight is we're going to be talking about aging and forgetfulness, kind of what we mean by memory loss, defining what dementia is, because there's still a lot of people who do not fully understand what the word actually means, and they use it in kind of maybe kind of incorrect context at times. We'll also talk about two other kind of conditions that can sometimes be misconstrued as being dementia and vice versa, and that's delirium and depression. Then we'll kind of go into kind of the more typical types of dementias and memory disorders, which Alzheimer's is one of them. Then we'll talk about treatment, and then if we have time, we'll talk about some of the future directions and things that are kind of on the horizon at this point in time in terms of the research. So starting off with memory, memory is actually a mental function that requires kind of a number of steps to kind of encode new information, store it, and then retrieve it at appropriate times. And the information could be any type of sensory information. It could be touch, it could be speech, it could be language, it could be visual, it could be auditory. But depending on the type of information and the source, your brain will kind of take that information and then follow it away to the appropriate parts of the brain to be retrieved down the road when it's required. So I use the example of a port to kind of give an example of what memory actually is. So if you can think of a container that comes off a container ship as being kind of a piece of information that your brain is receiving, the container is a shipment that needs to go from A to B. So when the container comes in, the container is brought into the port, it's tagged, and then it's stored, and then once it needs to go to Walmart or Fortino's or Longo's, whatever, then it's taken, because we know where it's stored, and it's taken to its destination. So similarly, when you have information, either visual or a piece of music, your brain will take that information, will store it in the appropriate parts of the brain, and then down the road, if you need to have it, you would have you will know where to get it, and then retrieve it accordingly. So it's kind of like a port. So I figured that was a nice example of understanding of how basically, when we talk about memory, how it actually works. And so, like I said, the different types of information is stored in different parts of the brain. And this is just an example slide, and I can't remember where I got this from, so nobody sue me or report me to whoever. Unfortunately, I forgot to put in the reference. But still, it gives you a good idea about kind of what parts of the brain is responsible for what type of action and information. So when we talk about, again, memory in general, I think basically the most important part of the brain that's responsible for memory and encoding memory and retrieving memory, it's a part of the brain called the hippocampus. And it's that part of the brain that looks like a slug and it's kind of flashing on and off. So it just gives you a bit of an anatomical kind of point to kind of think about when we talk about memory. And so, like I said, different parts of the brain store different types of memory. So when the information comes into the hippocampus of the brain, it kind of registers that information and then it kind of follows its way to different parts of the brain. So the back part of the brain is responsible for visual information. The middle part is storing information, emotions, music, sounds, noise, things like that. So the information goes to different parts of the brain depending on whether there is a visual information, auditory information, and so on. So as I mentioned, memory, for all intents and purposes, the most basic breakdown of it is that you have a piece of information comes in, your brain registers it, retains it, and then recalls at a later date. Now, memory can be further broken down, again, basically into two different types of memory. One type of memory is called procedural memory, and that type of memory is kind of more of learning how to knowledge about skills, how to do certain things, like throwing a ball, riding a bike, things like that. And that information is stored kind of in the lower parts, kind of in the inner parts of the brain. While another type of memory called declarative memory, which is knowing about information, what certain things are, that's kind of stored in the upper part of the brain, or the cortex, as we would call it. And the declarative memory is the type of memory that we're particularly quite interested in when we assess people with memory disorders like Alzheimer's disease, because that's the type of memory that usually is affected first. So with the declarative memory, that can be further broken down into two other types of memory called semantic memory, which is knowing about certain things, like who's the Prime Minister of Canada, who's the President of the United States, and then also episodic memory, knowing when certain things have occurred. So it's kind of like a diary. So when was the last time you went out to dinner? When was the last time you went out for a movie? And so on and so forth. So when we talk about memory loss, we do use the word amnesia sometimes, but we don't use it very much anymore because with Hollywood and movies, people kind of get amnesia mixed up with a lot of different things. However, if we are going to use the word amnesia, there's two types of amnesia in medicine that we do talk about. We call it retrograde amnesia and kind of the future type of amnesia, or anterograde amnesia, meaning difficulty learning new information. So when we talk about Alzheimer's disease and different types of dementia, the type of amnesia that we're talking about isn't actually retrograde amnesia. It's because that's the information about things in the past. What we normally find is that with Alzheimer's dementia and different types of dementia, there's some kind of process that affects the brain. And when it affects the brain, it causes the brain to have difficulties in learning new and storing new information. And that's what we call anterograde amnesia. And that's actually the type of amnesia that we actually see in people with Alzheimer's disease and different types of dementia. The past memories don't usually get affected first. I mean, eventually with time they will, but usually what we see first is anterograde amnesia, difficulty learning new information and retaining it and recalling it. So this slide just kind of defines it a little bit more, and I won't spend too much time on that as we've already talked about it. So one of the biggest myths in society is that memory loss is actually part of normal aging. And studies have shown over and over again that's absolutely not true. As we age, we actually don't lose memory. What happens is that as our brain ages, as our body ages, we just can't do the same things as we used to. So for example, we can't run, we can't run as fast as we can't jump as fast as we used to. And certainly when it comes to the brain, you can't learn things as fast as you used to, and you can't kind of bring out the information that you want or recall information that you want as fast as you used to. But given time, you are able to do those things. So you don't actually lose that ability. So for all intents and purposes, no, we don't lose our memory as a natural aging process. So when we do find that we have trouble with recalling certain things, it's what we would call benign senescent forgetfulness, meaning that, yes, eventually with time, some people may have difficulties recalling information, but it doesn't kind of affect their day-to-day functioning. Another term that has been used to describe that kind of condition is mild cognitive impairment, or MCI. And some of you may have heard that term a little bit more than the benign senescent forgetfulness. But generally, that's kind of what it's saying, is that we have people who have MCI or benign senescent forgetfulness have difficulties with short-term memory for things, or difficulties learning new information, but it doesn't really affect their day-to-day functioning, and it certainly doesn't kind of affect other parts of their thinking ability, such as recognizing people, or having any difficulties with comprehension of language, or expressing themselves, and so on. However, when we talk about a dementia, we don't only just talk about memory loss. We talk about memory loss in conjunction with other thinking ability losses that affect a person's ability to kind of function day to day. So in order for us to call something a dementia, all those factors have to be in place. So this diagram is basically showing you that there is a continuum of changes in memory as you get older. So normal aging, as I said, you do have difficulty sometimes learning new information. It takes a little bit longer to learn new things. It takes you a little bit longer to remember information. But at the end of the day, you actually don't have memory loss, because given time, you are able to learn new information. Given time, you are able to recall the information you need to recall. However, as some people age, they will move from normal aging memory issues to what we call mild cognitive impairment. In that condition, people subjectively and objectively are noticed to have difficulties with short-term memory, not long-term memory, and it doesn't affect their abilities, such as their language or their ability to kind of recognize things or to do things, and certainly it doesn't affect their function. But on testing, we do see that the short-term memory is a little bit worse in people with mild cognitive impairment versus people with just kind of normal aging memory changes. And then you have people who have dementia, where they not only have memory loss, but they also have other thinking and mental functioning abilities, to the point that it affects their day-to-day ability to do things. So that's kind of a continuum of kind of memory loss when we look at it in people who complain about memory problems. So getting on to kind of talking about dementia. I've already kind of said earlier that dementia, when we talk about dementia, we don't only just talk about memory loss. We actually talk about memory loss in conjunction with some other kind of mental or thinking ability changes. And it has to be in conjunction with affecting their abilities to do things on a day-to-day basis, such as balancing the bank book, remember to take the medications, making a meal, etc. Dementia is not a disease of itself. It's actually a category that encompasses different types of diseases or disorders that causes memory problems. It's an umbrella term, and again, as I mentioned on before on the slide, it says that it does have to incorporate memory loss with other brain functional changes, and it has to affect your ability to do things on a day-to-day basis. So what we normally see when people with dementia who have memory loss or that's associated with dementia, what we normally see, especially in Alzheimer's disease, is that there is a gradual decline in short-term memory. It's very slow, it can be insidious, and it would take anywhere from months, but more normally years before people kind of notice these changes. They have difficulties learning new knowledge. They have difficulties with performing certain types of tasks during the day. They may have increased periods of confusion at certain times, especially when they're ill. They may also have difficulties with their language, both expressive, meaning that they may have word-finding difficulties, or receptive, meaning that they have difficulties understanding or comprehending what is said, what they're reading, so on. It can further progress into affecting their ability to reason and to judge. So they seem to be more impulsive. They may make bad decisions. They may not fully understand and appreciate certain things that are happening in their life. It may also progress to personality changes. as well as behavioral problems or behavioral changes, meaning that people can become verbally agitated or responsive. They can be physically agitated or responsive. And those are things, as we'll talk about further, actually is not that uncommon. So we'll talk about that a little bit more. So that's kind of a general introduction to memory, what memory loss means, or what we mean by dementia. I'll move on and talk about a couple of other conditions that begin also with the letter D that can cause changes in person's concentration, quote-unquote memory, and may be mistaken for dementia and vice versa. So the first condition is called delirium. And this one is very often mistaken for dementia because in this condition, people are also very confused. However, unlike a dementia, people with delirium, the confusion and the memory problems come on very quickly. And when I say very quickly, I do mean hours to days. While people with dementia, the symptoms come on very gradually over years. People with delirium not only are acutely confused, very confused, but they also have trouble focusing. They have trouble attending. They can't concentrate and focus for a very long time. Within even the span of a day, a person's level of confusion can kind of fluctuate. 1 hour, they could be quite alert and seem their normal selves. And then 2 or 3 hours later, they can be quite confused. And that can happen very quickly in a span of a couple hours. Again, as I said, the onset of the disease is usually very quick compared to a dementia. And it's an important diagnosis to make because oftentimes people become delirious. The cause is usually some kind of a medical or medication-related problem. And we know from research that people who have delirium, who go undiagnosed or unrecognized, there's a 30% mortality rate. So it is quite significant. So it's really important that not only caregivers, but also doctors, nurses, and other healthcare professionals are aware that memory loss is not equal to memory loss. It depends on things like when did it start, how fast is it progressing, what are some of the other associated symptoms and signs that you see. And delirium is one of the ones that we always try to hit home to family physicians, emergency doctors, nurses, so on, that it is an acute medical emergency. So it's very important to try to figure out what's behind or causing the delirium. Depression is another condition that oftentimes can cause people to have trouble with quote-unquote memory. But depression is a little bit different as well in that it doesn't come on as fast as the delirium, but it also doesn't take as long to occur as a dementia. So people with depression, the symptoms may come on weeks to months. They may complain of memory problems, but they actually don't have problems with the memory. What we do find is that they actually have trouble with concentration or attention, which is actually one of the symptoms of depression. So the other symptoms of depression, besides feeling depressed, is that they can have trouble with sleep. They can have trouble with their with interest. They may not feel like they want to do anything. They could have trouble with their appetite. It could be increased, it could be decreased. They may have trouble with kind of their energy level. They may even have thoughts about wanting to die and so forth. So, and concentration loss is actually one of the symptoms of depression. And with seniors, it's very oftentimes confused with a dementia because they can't attend. So if you can't focus and you don't register the information, you're not going to remember it. But that doesn't mean that you have a dementia. It just means that you just didn't pay attention. And that is very common in people with depression. And when we see people with memory loss, we always do screen for depression as well. Other kind of things that could make you think about depression is if the person has a history of depression themselves, if there's a family history of depression. And oftentimes the person who have depression will answer questions when we talk to them. We'll answer questions with, oh, I'm not sure, I don't know, ask my wife or husband. They're very vague because you just can't be bothered. Okay, so this is kind of a natural kind of switch over to the next section of my talk. This is my cat, Simon. I've been doing this talk for about 10 years, and he's always been in my slides. So anyway, you guys are probably like him right now, just kind of easing back and just relaxing and listening. So So we'll move on to different types of dementia now. So I only have about I have 4 types of dementia up there, but I can assure you that there's a lot more types of dementias. And the 4 that I have up there are what we call neurodegenerative dementias or irreversible dementias, but they can also be reversible dementias, quote unquote. Things such as hypothyroidism, low B12, and other medical conditions can sometimes lead to conditions that look like a dementia as well. But if you kind of, quote unquote, fix the problem, what's underlying, oftentimes you do get a reversal. However, that's not the norm. The norm is the majority of dementias are irreversible dementias, and the majority of them are what we call neurodegenerative, meaning that it's due to a degeneration of the neurological path and electrical system in the brain and the chemical system in the brain. And oftentimes when that happens, because the brain doesn't have the capability to restore itself, to heal itself, like a lot of your other parts of your body, it is generally irreversible. So once the process starts, unfortunately, it cannot be reversed, at least not at this point in time. So the 4 common ones that I'm going to talk about tonight is Alzheimer's disease, and by far that's the most prominent one. Then you have vascular dementia, Lewy body dementia, and frontotemporal dementia. So I think in order to talk about dementia, we also have to talk about who's at risk for dementia. And as I will kind of talk about later, the most common, actually the most important risk factor and the most consistent risk factor is age. As you get older, your risk of developing dementia, irregardless of whether you have a family history or not, is going to increase. That's just life. And why that's important is because the population throughout the whole planet, actually, with the few exceptions of certain countries, is invariably getting older. And in Canada, we can see that the population is no different in terms of the future rate of increase. So the fastest growing population is going to be the seniors, 65 and older. The fastest category of that's going to be increasing in the future is going to be 85 plus. And just to let you know, last year was the first year, the tip of the iceberg, the baby boomer generation turned 65. So the first wave has turned 65 last year. So we're just going to get more and more people who are 65 and older. And as I said, the most consistent risk factor for dementia is age. So the prevalence, so the total number of people and also the risk of dementia increases with age. It basically doubles every 5 years after the age of 60. And in 1991, the information is a little bit dated, but generally it kind of communicates the basic idea that as we get older, the number of cases of dementia increases over time. So last year, we figured that we've had more than 100,000 new cases of Alzheimer's disease. And by 2031, about 750,000 Canadians would be diagnosed with Alzheimer's or another form of dementia. When you look at the kind of proportion of seniors in Canada, by that time, by 2031, 2040, thereabouts, probably about 18 to 20% of our population are going to be comprised of seniors, compared to 12 or 13% right now. So, as I mentioned, Alzheimer's disease is the most common form of dementia. It comprises anywhere from 50 to actually 70%. I said 50 to 60, but depending on the literature and what source that you read, it can be as high as 70, 75%. It was first diagnosed by Dr. Alzheimer's, and actually when he first put together the constellation of signs and symptoms that would eventually be named after him, Alzheimer's disease, he was actually a neurology resident. He wasn't even a full training specialist at the time. So it's quite interesting. His first case was also atypical in that it was a lady who was 51 years old. That is very, very young by even today's standards to be presenting with symptoms that would be considered Alzheimer's disease. But nonetheless, this was his first kind of case. This lady presented with not only decline in short-term memory and mental function, but she also had symptoms such as delusions, which are fixed false ideas, so probably paranoia, believing that people were trying to come in and steal things from her, or thinking that her husband was having an affair, what have you. It could be any form of the kind of fixed false beliefs. She was also having hallucinations, and hallucination can come in any form. Could be visual, auditory, olfactory, meaning smell, taste, tactile, feeling like somebody's touching you. But the most common type of hallucinations that we see in people with dementia is usually visual related. So for her, visual hallucinations were prominent. We also have cases where it's auditory, but again, visual is usually the one that we run into most with people with dementia. So Dr. Alzheimer's is on your left, and the first client, actually her name is Auguste D, or I think her last name was actually Dieter. That's her on the right, and again, even from those pictures, she looked much older for her age than 51. So although we know a lot of things about this disease, there's still a lot of things we don't know about this disease, and the exact cause of the disease is actually still not known. We don't know why this starts, and we don't know what the cascade of events are that kind of cause the damage. What we do know is that even from the days of Dr. Alzheimer's is that there are hallmarks of the disease. So we can see the trail of destruction, as it were. So the trail of the destruction, the most two common trails of destruction are the amyloid plaques and the neurofibrillary tangle. We see the destruction, we just don't know what causes it. But these are the two common hallmarks of the disease. In addition, we also see that on pathology, when you do an autopsy of people with dementia, we see that their brains are generally much smaller. And today, we don't actually have to do an autopsy anymore. We can actually sometimes see that on a CAT scan or MRI. But having said that, not everybody, even with people with severe dementia, may not have shrinkage in their brain on neuroimaging either. So it's not always a kind of hard and fast rule. So besides kind of this brain size, we see this, when under the microscope, we see that the cells, the neuron cells, the brain cells are actually smaller. The number of brain chemicals, particularly those related to memory, are also less. And there can be also other changes such as inflammation and other things that occur during this process. This slide I won't kind of stay on. It just kind of should show you on top are the tangles, and on the bottom are the amyloid plaques. So this slide basically is meant to demonstrate that when you look at the brain, the autopsy brain, and when you look at the slides of the brain cells and the slices, what you find that generally people who have Alzheimer's disease, a lot of the plaques and tangles are actually centered around the hippocampal area. The hippocampus was where we talked about before. And the disease eventually will progress to other parts of the body, as you can see by these little other dots. But most of those people, especially those people who are up close, can see that a lot of the dots are concentrated in the hippocampus area and the entorhinal cortex and so on and so forth. So that's just going to show, to kind of hit home the point that the trail of destruction is vast. It goes throughout the whole brain eventually, but it is concentrated in the hippocampus because that's likely where it starts. So it's kind of almost like a bomb crater. The biggest crater is in the center where the bomb hit, and then the destruction kind of goes from there. It's just kind of the same idea. So this slide is just, again, meant to show you that there can be shrinkage in the brain, especially in people with Alzheimer's disease. So the first one on your left is a normal brain. The middle brain is somebody with moderate dementia. And then the one on your right is kind of severe, advanced, kind of terminal dementia. Again, the B one is just kind of the same brain, but through a different slice. So we don't know exactly what causes Alzheimer's disease, but we have a suspicion that there is a process, and what we think the process could be is that you have a protein called amyloid precursor protein, which is actually a normal protein. It's in everybody's brains. When we're young, the mechanism that kind of breaks down this protein and uses it and makes it into a usable component is quite fine, so everything's okay. But as we get older, our body's mechanism, something changes, especially for those people with Alzheimer's disease. Something happens in the brain that causes the processing of this protein called amyloid precursor protein, or APP, to kind of produce or kind of change this product into something that's potentially lethal and is a hallmark of dementia or Alzheimer's disease. So what we do know is that there are two enzymes, or kind of that kind of breaks this protein down. So it's these two form a product from APP that is potentially lethal for brain cells. We don't know why they're there, we don't know why they do it, but that's what happens. What happens, so when they make this APP, it turns into kind of long strands of protein called beta amyloid. It stays in your brain cells, but eventually it's extruded out. When it's extruded out, these different pieces of beta amyloid will kind of congregate together and cause an amass and turn into what we call plaques, or amyloid plaques. So that's kind of hypothesis of what we think happens. So that's the trail of the destruction, but we don't know what causes the destruction. It's almost like if you kind of come across a car accident on the road, on the highway, a multi-car collision, you can see the trail of destruction, you just don't know what caused it. Kind of the same idea in Alzheimer's disease. So I'm going to show a video now that kind of explains that probably a little bit more eloquently than I, and also gives me a chance to rest my voice as well. So anyway. So this video is, or DVD is from a series that was originally run on PBS called The Forgetting. It's actually, there's a book by the same name as well. And I think the Acclaim Health has copies of this. So this is the video where this excerpt is from.
The human brain is a miraculous and complex organ that controls every breath, thought, heartbeat, and emotion. This amazing network is maintained by carefully orchestrated chemical and electrical signals traveling on massive...
In terms of Alzheimer's disease, as I mentioned, the confirmed risk and the most consistent risk is old age. But there are other things such as a family history of dementia that increases your risk of developing Alzheimer's disease or any other form of dementia for that matter. History of vascular disorders. We know that now diabetes, high blood pressure, poorly controlled heart conditions can also increase your risk of dementia. Just because it can also cause what we call cerebral vascular changes, so people could be at risk for not only strokes, but also just long-term insufficient blood flow to the brain, which kind of causes damage over time as well. Having kind of not an abnormal gene, but a variant gene called ApoE lipoprotein can also increase your risk of having Alzheimer's disease as well. But just because you have one copy of this kind of variation, or even two copies for that matter, doesn't guarantee that you have this disease. It just has you at a higher risk compared to the normal population of people who don't have that variation in that gene. One thing that most people don't realize is that generally there is actually two forms of Alzheimer's disease. You have the sporadic form of Alzheimer's disease, which is the majority of people get this type if they're going to get Alzheimer's disease at all. It comprises about 95% of people with Alzheimer's disease. However, there is a small population of folks who develop what we call early onset Alzheimer's disease, or what we call familiar Alzheimer's disease. And these people actually have a very high genetic kind of a correlation between mutations in the certain types of their gene and developing this disease. Luckily, it is the less common form of the two, just because the early onset Alzheimer's disease or familial Alzheimer's disease is, as I mentioned, is an earlier onset form. So instead of people developing it when they're 65 or older, they develop it much earlier. I've had a case where the history started actually in their late 30s. And recently we've actually had a lot of cases of early onset Alzheimer's disease, people getting in the mid 40s, early 50s. This is by far the most challenging type of dementia that I see. Oftentimes I'm left with a lot of feelings of helplessness because invariably these folks will have a lot of kind of personality and emotional changes that is very, very, very difficult to find something that will help kind of mitigate or kind of help calm them down and give them some peace. It is a very difficult form to manage. There is a strong genetic component to this. So mutations in chromosomes 1, 14, and 21 have been shown to be strongly associated with this disease. Someone with these gene mutations will unfortunately develop the disease. It is that kind of highly correlated. For those of you who have some biology background, you may know that chromosome 21 is also associated with Down syndrome. And we now know that people with Down syndrome invariably will get Alzheimer's or form of dementia kind of in their 40s and 50s. So it's kind of interesting just to kind of let you know about. The sporadic form of the disease, again, luckily is the more common form of the two. Not saying that it's lucky to have this disease, but if you were going to have one or the other, I would prefer to have this one. It is the most common form. 90-95% of the population will have this form of the disease if they get it at all. It's what we call the late onset form of Alzheimer's disease. There is an increased risk if you have a gene variation, but again, like I said, it does not mean that you will get it for sure. It just means that you're a higher risk. In terms of how this disease progresses, as I mentioned before, it does start insidiously, slowly, and as the DVD said, imperceptibly at first. It usually starts with short-term memory problems beginning, but then it can progress as the disease progresses through different parts of your brain. Your language ability can be affected. Your ability to identify and recognize people, places can also be affected. Your ability to do certain activities or certain skills will become lost because you can't remember how to perform them as well. And ability to kind of perform more complicated tasks, such as cooking a big meal or taking a complicated medication regime, could also be affected as well. So in the mild stages, you will run into difficulties such as having trouble with people's names, balancing checkbook, making a complex meal, difficulty with a kind of complex medication schedule, forgetting appointments, and so on. Sometimes it can also affect people's driving. We've had cases where people have difficulties remembering how to get to kind of places that you used to be able to get to no problem at all before. And we'll talk about driving a little bit more in a moment. As the disease progresses, even simple meal preparations become more difficult. Household tasks become more difficult. They may have difficulties remembering certain parts of their history, such as their grandchildren's name. Sometimes their children's name at this stage, but usually much later. You may see the parents' personality changes and also changes in their behaviors as well. Trouble with directions, can't find their way home, get lost driving, and some aspects of self-care. Can't remember when they took their bath last, thought they had a bath, but really they went for 2 weeks without one. Things like that will start to happen. At the most severe stages, the person will need assistance with pretty much all aspects of their care. The meals will have to be prepared. They have to be monitored for taking their medications, problems with expressing themselves, sometimes problems understanding what people are saying to him or her. They may have trouble with movement. They may have trouble recognizing familiar faces or people that they should be able to recognize. And generally, they will require more care. And then at the profound stages and at the end stages, most times they're pretty much kind of almost bedbound in some cases. And as you may notice that I used kind of a melting ice on the bottom of each of these slides. And basically what that was meant to do, and another example is also an onion as well. What that basically is trying to say is that when you first are born, you develop and you have certain skills. And all those kind of early memories, early skills are kind of in the center of the ice or center of the onion. As you get older and you kind of add to your knowledge and your skills, the ice gets bigger and bigger or the onion peel gets bigger and bigger. But Alzheimer's, basically in chronological order, strips away your development. So it's almost like peeling the onion backwards or melting the ice. So all your long-term memories are more in the center of the ice or center of the onion, and your newer memories are on the surface. So that's why when you start having this problem, you actually have trouble with short-term memory first, because all those long-term memories are still in there, still not affected yet. But as time goes by, they will also get affected as well. So this talks about the kind of the end stages. The video says kind of anywhere from 5 to 20 years. 20 is a little bit long from my experience, but certainly 5 to 10, maybe even 15 is not kind of unheard of. And usually people ask me, well, what happens at the end? At the end, as the video has said, eventually even parts of your brain that's responsible for breathing, coughing, swallowing will become affected. Most times, people don't just stop breathing. What happens is that people have difficulties coordinating the muscles as they swallow. They have trouble swallowing water, food. Sometimes it goes down the wrong way. They get a pneumonia, and that's usually the cause of death. So this kind of slide is just to show you kind of the progression of the disease over time. When we talk about dementia, when we diagnose a person with dementia, we can say that, you know, it's probably Alzheimer's disease or it's probably Lewy body disease, and that's kind of as good as it gets, because the only way you can confirm the diagnosis for sure is if you do an autopsy. You kind of look at the brain. Do they have the plaques and tangles or the other kind of chemical changes that happens in the brain? And that's when you can make the diagnosis for sure. However, even when we take a good history, when we do a physical examination, when we couple that with neuroimaging, blood work, so on and so forth, when we make a clinical diagnosis of dementia, oftentimes we're about 80% right, 80 to 90% right, and studies have kind of confirmed that. So even the clinical diagnosis of probable Alzheimer's disease or probable Lewy body dementia is actually, we're pretty close. 80% is pretty good. So that's why when you go to a specialist appointment with a loved one, especially for a person like myself, we ask a lot of questions, but that's because we have to kind of put it into all the pieces and kind of look at the whole picture. We don't just look at one part of the picture. Now, having said that about the autopsy, there is something called positron emission tomography or PET scanning that's only available in very kind of tertiary care centers, university hospitals. Certainly we have one in McMaster, and Toronto has one, but still used mostly for research. However, there has been a number of compounds, radioactive compounds, that have been developed over the years. Toronto have their version, Pittsburgh in the States have their version, and almost every major center in the world, university center, has made some form of their own variation of this type of compound. And what this compound, these types of compounds do is that it actually, when it's injected into you, these compounds go into the brain, crosses into the brain, and it actually sticks on to the plaques that are kind of the hallmark of dementia. And what can happen is that when they stick on, we can actually show it on the PET scan. And we can scan your brain on the PET scan, and those little radioactive ligands, we call them, that attaches to the plaques, light up on the PET scan. You can see it all over the brain. And I may have some pictures of that later on. But just moving on in terms of making the diagnosis, as I mentioned, the most important part is actually doing a medical history. And that's where caregivers and loved ones come into play, because it's very oftentimes folks with dementia don't realize things are changing, and they may not, there's many times people come in and say, oh, I don't think there's anything wrong with me. My wife says my memory is not very good, but I never really noticed anything. But that's why the collateral history is so vital, because we need to have an objective kind of observer kind of noticing what some of the changes are, because part and parcel of the changes in your brain is ability to recognize that there actually is something wrong. And so it's kind of like, I tell people, it's almost like, the example of you're driving, you ran out of gas and you suddenly don't know why, but your meter says you're on full. But actually, when you bring it to the mechanic says, well, your meter is broken. That's why you ran out of gas and you didn't know. So the brain is kind of the same way. When you have Alzheimer's dementia, your brain is affected in some way that makes your ability to know that something is wrong is actually affected, and you don't know something is wrong. So that's why having that collateral information is really, really vital. We also do what we call mental status evaluation. So we do these kind of tests, how many numbers you're going to remember, how many words you're going to generate, so on and so forth. Then some of us do physical examinations sometimes, because we want to make sure that there isn't some other neurological condition that could be causing this, because not all other neurological conditions can also cause dementia as well, such as Parkinson's disease. So we kind of do a physical examination at times. Certain specialists, like a neurologist and geriatrician, may do a little bit more than somebody like me who's a geriatric psychiatrist, but I still kind of do some basic stuff depending on the case. Then we certainly ask for lab tests, because, like I said, we're looking for reversible causes of dementia, like hypothyroidism, anemia, low B12, things like that. But most of the times, especially when seniors present to us with memory problems, and we're ruled out delirium and depression, a lot of times when they do have a dementia, it's usually kind of the non-reversible type. But we also look at a psychiatric and psychological evaluation as well, and again, ruling out depression and other things. All right, so we're moving on to Lewy body dementia. At one point in time, this was thought to be the third most common dementia, but more of the research is showing that it's probably more like the second most common form of dementia, because doctors are now knowing more and more about this condition, and the diagnosis is becoming more prominent. So at one point we thought it was maybe 5 to 10%, but maybe realistically, maybe more like 25% of dementias are actually Lewy body dementias. And this dementia is quite different. It's a little bit different than Alzheimer's disease because it actually has symptoms of Alzheimer's disease, so the memory loss and other functional changes in the brain changes, but you also have neurological symptoms of Parkinson's disease. So people actually have the tremors, they may have the shuffling gait, and kind of the mask face, so they have symptoms of both Alzheimer's disease and Parkinson's disease. And what also sets this disease apart from Alzheimer's is that very early on, folks who have this form of dementia have what we call visual hallucinations. They actually see people, animals, children in their home. They also have very kind of varying course in their level of confusion. Sometimes it can be muddled one day, and later on in the afternoon they're not as muddled, they're kind of almost back to normal self. Not quite as quickly as a delirium, but certainly kind of has more of a fluctuation in their memory and compared to Alzheimer's disease, which is kind of more of a constant throughout the day. And oftentimes these people, because they do have hallucinations, when we do try to provide them drugs to kind of decrease the hallucinations, they seem to be a little bit more sensitive to it, meaning that they can cause more side effects such as shaking and stiffness and things like that. Sometimes these medications can make them even more confused. So we have to be careful, but not that we can't use them, we just have to be more careful about using those types of medications. Vascular dementia was thought to be second, but maybe more third now, because people who have pure vascular dementia probably are not as common as we used to think, especially when you look in the context of these folks. To make the diagnosis of vascular dementia, you have to not only have symptoms of Alzheimer's disease, but it has to be in context of after having a stroke, demonstratable on CAT scan or MRI, and you also have to have neurological deficits as well. So when you kind of look at the criteria for vascular dementia, probably is not as common as we used to think, at least not pure vascular dementia anyway. Anyway, these people who are affected by this are usually people in their 60s and 70s, people who are older. Occurs in men more than women, but again, that makes more sense because men are at risk of cardiovascular disease compared to women, or more at risk compared to women. It's usually caused by a series of strokes in the brain. And the strokes can either be a clogged blood vessel or it could be a hemorrhage of some sort. And either type can cause a stroke. Sometimes people who have long-standing insufficient blood flow to the brain can also eventually over time have the same type of damage, but it doesn't happen as fast as a stroke does. Again, this slide is just to show you kind of a damage that's done from a stroke, and this is actually a bad area because that's actually where the memory functions are. You could still have a stroke, but you may not have memory problems, but depending on where stroke hits, you could have a memory problem. So risk factors for vascular dementia is basically the risk factors for cardiovascular disease in general. So high blood pressure, poor diabetes control, high cholesterol, abnormal heart rhythms or uncontrolled abnormal heart rhythms can cause a person to have a stroke and therefore be at risk for vascular dementia. It's actually a risk factor for Alzheimer's disease as well. So symptoms usually come on fairly quickly, the stroke that is, and usually if you do have a memory impairment, it comes on within the first 6 months according to definition of having a stroke. That's kind of the time period. And the problem is that when you have one stroke, you're going to be at risk for further strokes. And every time that you get affected by a stroke, you have a decline in your cognitive function and your functional ability. So that's why they call it a stepwise deterioration. And again, as I said, the presentation after a stroke really depends on where it hits. So just because you've had a stroke doesn't mean that you can't move an arm or leg necessarily, nor do you have memory problems. So again, it just depends on where the stroke occurred. Sometimes people have what we call mini strokes or transient ischemic attacks or TIAs. But if you talk to some of the neuropathologists around these days, they will tell you that there's no such thing as a transient ischemic attack because when you actually have a TIA, and on some level there is actually damage. So TIAs for at least some neuropathologists is a misnomer because there's no such thing as a transient ischemic attack. You have an ischemic attack and you have damage. But again, it's kind of an area of controversy still, but nonetheless, I think the whole idea is that it's really important to try to control your blood pressure, your cholesterol level, your any kind of heart conditions you may have, to decrease your risk of having a stroke, but also vascular dementia and also Alzheimer's disease. There are some people who can have symptoms of both type, Alzheimer's disease pathology as well as kind of stroke pathology to cause memory problems. We call that mixed dementia. We can also have mixed dementia when people have components of other types of dementia with Alzheimer's disease and so on. So, but the point of this is that yes, you can have both symptoms of vascular dementia and Alzheimer's dementia together. And then the fourth kind of most common form of dementia is frontotemporal dementia. And what sets this one apart compared to the rest is that all the other ones that came before this one do present with memory problems in the beginning. People with frontotemporal dementia do not present with memory problems in the beginning. They present with personality changes and behavioral changes in the beginning. So people may oftentimes be sent into people like myself or other mental health workers, and they say, you know, I think you have a depression, or I think they have manic depression, and so on and so forth. But when you take the history, you don't have that kind of long-standing mood disorder picture. You kind of see this sudden change within probably the last 1 or 2 years of a person who used to be a very kind of upstanding citizen start to smoke marijuana, go to raves, they start shoplifting, they start kind of proposing to people, women on the internet or men on the internet, kind of, they might start setting fires and so on and so forth. So you may have changes in personality and behaviors that are really atypical for that person. Or a person who used to be very sprightly, very lively, may become very kind of apathetic, they don't want to do anything, they seem very, very depressed, but if you ask them what's wrong, they don't think anything is wrong, everything is fine, but at the same time, they're totally unmotivated. So those are the variations that you can see in people with frontotemporal dementia. So that's when we think of the frontotemporal dementia, that's kind of the classical form of frontotemporal dementia that we see. However, we also see people with frontotemporal dementia who presents with language deficits. So they may have profound difficulties with word finding or expressing themselves. Some people present with profound disability in understanding and appreciating what certain words actually mean, the meaning of words, and so on and so forth. So that is also classified as a frontotemporal type of dementia as well. But usually when we talk about frontotemporal dementia, the consensus is most specialists and most doctors, when we think of frontotemporal dementia, we think about the behavioral variant of frontotemporal dementia. Again, the reason why we call it frontotemporal is because it affects the front part of your brain and the sides of your brain, the temporal lobes, which was where the memory is. The reason why the frontal lobe is important is because that's basically is almost like the CEO of your brain. It's your ego, as Freud would put it. You're in your ego. Well, this is your ego. It kind of is responsible for judgment, responsible for abstraction, responsible for organization. It's kind of who you are in terms of your personality. It's kind of like the brakes in a car, right? But when the brakes of the car starts to go, so does the rest of your brain, and your ability to kind of hone in and kind of restrain some of those impulsive things and that you would want to do but you don't do. When that goes, then you start seeing these changes in behaviors. So that's why frontotemporal dementia although it's called dementia, you present with personality changes, behavior changes first. The memory problem does occur eventually because as the damage proceeds, it will also affect your memory, but the first signs are usually behavioral changes and personality changes. So we're going to look at treatment. So in terms of treatment, when we talk about treatment, we don't just talk about medications. I think a lot of people think that, you go to a doctor, blah, 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 they sit down, what's your problem? Okay, we'll give you a pill. Sure, medications is one part of the treatment, but really we need to kind of look at the overall picture. We need to look at medications and non-medication things to address. So the first thing is, again, as I've been saying, is that we need to assess for medical reversible causes of this memory problem or memory loss when people come in complaining of that. But we also look at psychosocial and behavioral intervention. So if in fact a dementia is what we're looking at, then really education for the client and as well as the family is very, very key and very important. But also with that knowledge, we're hoping to work in conjunction with the treatment team and their family members to try to kind of recommend a plan that will help ensure the person's safety. And that includes things such as powers of attorney, wills, and also things like driving and so on. So those are other things that it's really important. Regular health monitoring, making sure your blood pressure is controlled, cholesterol is controlled, diabetes is well controlled. Those are things that need to be done. And then certainly we talk about medications. But before I talk about medications, I want to kind of get on the driving safety issue, because this is actually a very difficult area for myself and a lot of specialists, because as I mentioned, dementia isn't just memory disorder, it actually affects other parts of your brain's ability to function properly. That includes distance, judging distances, motor abilities, hearing abilities, processing information, and so forth. Driving is actually a very complicated task, because it's not only about knowing where the pedals are and how to steer a wheel. You have to be able to know where you're going, how to get there, plan a route in your head, be aware of other sensory stimulus, be aware of other cars, other drivers, pedestrians, so on and so forth, weather conditions, day and night conditions. So it's actually a very fine balance. We do all take it for granted doing this, but it's actually a very intricate process that goes through your brain. So just imagine if your brain, if that computer is affected in some way, it's kind of just common sense, that your abilities to do complicated tasks like that likely is going to be affected. So driving safety is always something we are of concern, because when we kind of assess that, people sometimes get really angry and say, well, you know what, I've been driving for 25, 50 years, never had a ticket, never had an accident, so on and so forth. Well, you know what, you've never been 75 either until now. So, I can't do things as I could when I was 25. So just saying that it never happened before doesn't mean that it's going to happen now. And when it does, and I can tell you, when it happens bad. It's all over the news, and and people are hurt invariably. So it's really important. So what I want to show is video clips of actually people with suspected dementia have gone for driving assessments. Again, unfortunately, I didn't, forgot to put in the reference, but I believe where I got this from was a colleague who actually went to a Drive-Able kind of company which kind of does the assessments, and they downloaded these images. So this is kind of where I got it from. So again, please don't tell Drive-Able and have me sued.
Straight through here. Straight through, straight through.
So again, I'm just going to play it for people who can't hear it, and I couldn't find the volume control here fast enough. But basically, the instruction was telling the driver to go straight through, and he said, straight through, and he said, yes, straight through, and he kind of ran into the median. So I'll just show that again.
Straight through. Straight through, straight through.
Right. So the second video clip is of the same gentleman, again, driving, and again, the evaluator actually had to take over actually had his hands over the wheel to pull it back, because otherwise he would have hit the truck. Yeah, just a little bit. So again, I don't mean to be facetious, but it is very scary when you think about this, because you are driving, and oftentimes we're kind of concentrating on the young, silly people who are going 10, 20 above the speed limit. But certainly, there are other dangers around. And certainly, even if you are an older driver and you're pretty good, you still also have to be aware of these other dangers. That's what I was saying, other distractions, other things. And again, even a normal senior may sometimes have difficulties kind of reacting fast enough, just not because cognitively, but even, they may have a neck problem or what have you. So again, driving is very kind of important to review as one gets older. And a lot of people think that driving is a given, that is, they're right, but it actually really is a privilege. And this is the final video. So she looks both ways, stops, looks both ways. And then the instructor had to put on the emergency brakes because the pedestrian was walking by. So in Ontario and many provinces, they have kind of legislation that obligates physicians to kind of report any kind of medical conditions that could affect their ability to drive safely. So in Ontario, we have the Highway Traffic Act. And what that obliges physicians to do, not just specialists, but any physician, it obliges the physician to report to the Ministry of Transportation any kind of medical conditions that could potentially affect the person's safety, ability to drive. It doesn't say that for sure it does. If there's a list of conditions that they have, and if you have the condition and it is felt that it may affect your safety, it's actually, we're obliged to report to the ministry. Not to do so actually would be illegal, and if something happened, it was found that we did not fulfill that obligation, we as physicians would be liable. Okay, so when we look at treatment, we kind of went through kind of the non-medication things, but now we're going to talk a little bit about the medications. So really at this point in time, despite everything that's gone on over the last 10, 15, 20 years, since the science has become good enough for us to kind of make some type of attempt to provide some kind of improvement to people's quality of life who suffer from this disease, at the end of the day, we're still not that far. The major class of medications we have are what we call acetylcholinesterase inhibitors, and basically it prevents the breakdown of a neurochemical in your brain called acetylcholine that's kind of responsible for memory, or at least take part in memory. The medication does not stop Alzheimer's disease. Its purpose is to slow down the rate at which you lose your memory or your brain thinking abilities or mental abilities, so that your abilities, your functional abilities, is preserved as long as possible. And the whole idea is that we're hoping that this medication can preserve you long enough that you can be able to stay at your home as long as possible without having to go to long-term care, and that your best before date will come up before the disease is so bad that you actually have to go into a home. So that's basically what these kinds of medications meant to do. So this is just a fancy example of the memory chemical, the acetylcholine. It comes over here and it goes over to the next brain, the synapse. So this is the synapse of what the video was talking about. This is one brain cell can communicate to another brain cell. So what the medication is meant to do is it actually tries to prevent this memory chemical from being recycled, because your body is actually very good. It's very good at recycling. However, when you have a disease like Alzheimer's disease, the actual number of these chemicals actually decreases. So we can't recycle things that we really don't have a lot of. So what that medication is meant to do is try to inhibit this enzyme, acetylcholinesterase inhibitor, from recycling the memory chemical. So by doing that, we have more of the memory chemical around. So the first medication was actually called Tacron. It was never formally available per se in Canada, but it was in the States. It never kind of made it too far because it was actually a very harsh medication, and there was a high likelihood that people would actually have liver toxicity from it. So it actually was pulled off the market. The medication that has been, therefore, by the loss of Tacron, donepezil is actually the medication that's been around the longest. It's the medication we know the most about in terms of efficacy, and also in terms of effects and adverse effects and so on. It is a once-a-day medication. It comes in 5 milligrams and 10 milligrams. Some people who know how I practice may know that I actually don't start people, at least especially older seniors, at 5. I usually start them at 2.5 and titrate them up by 2.5 up to 10. 10 milligrams has been shown in studies to be the most effective, but it also is the dose that has the most potential for side effects, which is only kind of intuitive, because the higher amount of medication, the more likelihood that you have some form of side effects. In the last year, there was a study showing that actually the donepezil or Aricept 23 milligrams has been effective in people with Alzheimer's disease, and actually the FDA went as far as kind of saying, okay, this is okay to kind of market this medication at 23 milligrams. I actually have a problem with that because, number one, it's based on one big study. But the other thing is that we don't have subsequent studies to show that 23 milligrams is that great. And also, as I mentioned before, the higher dosage of medication increases your risk. So again, are we going to get much benefit from the higher dose? The other issue to take into account, and again, I'm not a lover of drug companies, but again, the patent for this drug was running out in 2010. And so it was going to go generic. So interestingly enough, people wonder why 23 milligrams, because you can't get 23 milligrams from either adding 5 and 10 together or 10 to 10 together. So it enabled this company to prolong its patent for at least another probably 3 or 4 or 5 years. So again, I'm not a big fan of the 23 milligram. And again, I don't think there's enough studies. And really, I don't think it's really adding a whole lot other than maybe increasing your risk for side effects. So it's not a medication that I use, and nor do I intend to use in the near future, unless something different comes out. Exelon or rivastigmine is the other medication. This medication is a twice-a-day medication. is generally a good, again, all these medications are pretty much dissimilar efficacy in terms of, and also very similar tolerability. The only difference with this medication is, unlike the other two, Aricept and also Revenil, which I'll talk about next, is that this medication is actually moved out of your body through the kidneys. So you actually have to have fairly good kidney function for you to use this medication. The other interesting point about this medication is now that it's available actually in a patch form. But the patch form in Ontario anyway is still not covered. But the reason why patch form is interesting is because one of the most common side effects of this class of medications is that it can cause stomach discomfort. And the patch actually bypasses your stomach. And people who are not able to tolerate the oral medication can actually tolerate the patch quite well. But again, the limiting factor is that you have to have good kidneys and you have to have a good pocketbook, because this medication costs about $150 a month, the patch. So galantamine or Revenil ER is the third one in this class. Again, it's a once-a-day medication. Again, I don't use this as much because I've used Aricept. It's the one I go to most of the time, and unless there's some real particular reason, I don't really use this medication. Sometimes I do use Exelon for certain things, but I rarely use Revenil. But again, not that it's a bad drug, it's just familiarity and preference. Because all of them have common side effects, and the common side effects are more stomach related. So people complain of vomiting, diarrhea, cramping, anorexia, but they can also complain of fatigue. And certainly in Aricept, initially, it was prescribed as nighttime, and we were told to prescribe it at nighttime. But what we found is that medication, particularly Aricept, can also lead to a lot of vivid dreams and even nightmares. So oftentimes, to mitigate that problem, we actually tell people to take it in the morning. So all the medications in this class, we actually have people take during the day, and we also have them take it after a meal, because we also find that when you have a full stomach, it also decreases your risk of having stomach side effects that I talk about. So that's why many times we tell people to take it in the morning, either after breakfast most commonly, or sometimes after lunch. Memantine or Abixa is a medication that's been around the block not that long in North America, but been probably close to 20 years in Europe before. At this point in time. And it works very differently from the other medication, class of medication. And the reason why this is important is because we know that from studies that when people who have this medication, in addition to Aricept specifically, but we think it's the same effect with the other medications in the previous class, that when people are on those two medications, they oftentimes do better than if they were on one of the medications or the other by itself. And because it works differently, sometimes people who can't tolerate the other class of medications, we usually go to this medication. But again, this medication, you require good kidneys and also a good pocketbook, because again, like the Exelon patch, the Abixa right now, at least in Ontario, is not covered. So again, the Abixa is usually used for kind of moderate to severe Alzheimer's dementia. The other class of medications for mild to moderate. Actually, if you look at the indications now, there has been a study within the last 5 years, the last one being from Sunnybrook, that kind of looked at the benefits of using Aricept and that class of medications in people with severe Alzheimer's dementia. So even with Aricept now, you have the indication for not only mild and moderate, but also severe as well. It's generally well tolerated. Going back to Abixa, it's generally well tolerated. So is actually the other medications generally for most people. It can cause problems such as dizziness, constipation, headaches, high blood pressure, and so on. And if you go up too quickly or too high on the medication, it can, for some people, make them even more confused and maybe even hallucinate. But that's why we kind of give, when we consult to family doctors, we give them very specific kind of protocol of when and how to increase the medication. This one you can't see very well, but I think is maybe in your handout in the back somewhere. It's just basically a table to kind of look at there are alternative treatments for Alzheimer's disease. And for all intents and purposes, because of time, I'm basically going to say all the studies have shown that none of these things really work, unfortunately. Ginkgo biloba by far has been the one that's been around the block the longest and had the most fanfare about, but in a 6-year long-term study that was completed about a couple of years ago, it showed in multi-center sites it was found to be not effective. So that's basically what I'm saying here about Ginkgo biloba. Talking about other medications that are sometimes used with people who, for people who have dementia. As I mentioned, not only do people have cognitive changes related to dementia, but you can also have what we call non-cognitive changes in dementia as well. And the most common are behavioral changes, changes in mental health, like neuropsychiatric symptoms like agitation, hallucinations, paranoia. Those can be very common in people with dementia. And like I said, the non-cognitive symptoms or complications can be as high as 80%. So having those symptoms is actually the norm and not the exception, unfortunately. So in order to address some of those symptoms, because they can be very problematic, not only for the client in terms of the quality of life, but also in terms of the caregivers and other people who live with them. So depression can be very common in dementia, Alzheimer's disease. It's anywhere from 20 to 30% in the community and up to 50% in people with dementia in long-term care. There are good medications to help depression. There was one big study in the last year or two that kind of questioned whether the utility of antidepressants in people with dementia. However, that's only one study. Until we see otherwise, we will continue to treat people with depression, dementia with depression with antidepressants, because it does actually, again, anecdotally from our own observations, it has improved quality of life for those folks who we know for sure have depression, which can be sometimes a little bit difficult to tease out, by the way. Anxiety is also very common in people with dementia. Again, we use antidepressants to treat those as well. People who have paranoia, hallucinations are treated with antipsychotic medications. There has been a lot of hoopla in the last 5 years or so about antipsychotic medications, especially things like risperidone and so forth, so on. Yes, those medications have been linked with increased risk for not only side effects, but adverse effects such as risk for strokes, pneumonias, and even death. However, the increase in risk is about 1.6 times the normal population. And you have to balance that between that increase in risk and what the person is presenting with. Because if this person is so paranoid that they're going around, they're hitting people, and they're stealing, kind of barricading themselves in a room, you know, and also being in that level of kind of hyper-awareness and agitation is also not good for your heart or your blood pressure. So, you know, yes, the medications can cause you to cause you harm, but so can that state as well in terms of not only for yourself, but also your caregivers as well. So you do have to kind of balance the risk and benefits of being on these medications. And I'm not saying that we put everybody on these medications, but certainly they do have their place. And so it's a matter of evaluating where these medications sit in terms of helping your loved one or not helping your loved one. So just a little talk about medications, particularly antipsychotic medications. So just to let you know, this is from 2008, but certainly it's still probably the case is that development or research and development medications still for people with dementia, trying to treat dementia, is still the kind of highest number of researchers going into that area, because that's really the holy grail. Whoever can find a cure for this disease got it made. They're going to be rich beyond their imagination. So there is a lot of development. The only problem is that, unfortunately, within the last 5 years, many of these highly touted medications that have had a lot of fanfare in the early stages of development and in the smaller studies, trials, when you went to the bigger studies, flopped miserably. But nonetheless, here are some of the new kind of technologies that we're looking at down the road, or it's currently being investigated. So one of the future directions, as I mentioned, is this Pittsburgh B compound or ligands, radioactive ligands that are meant to kind of hook on to the plaques specifically to light it, kind of to show who may have Alzheimer's disease. And why this is important is because the idea is that the earlier that we can catch it, the earlier we can intervene. But it may also mean that we can find interventions much earlier to help develop new medications earlier. We kind of know what may be happening. Because right now, as I said, we still don't know why this all occurs. We can see the trail of the destruction, but we don't know why it occurred, how it occurs. So that's one future. The other part of the future, other future directions are the vaccine. We talked about the Alzheimer's vaccine. And that's basically trying to use your own body's defense system to kind of attack and to deal with the Alzheimer's pathology that's going on in your brain. So initially, there wasn't a vaccine back a number of years, probably close to 10 years ago now, where they did a study and they showed that this vaccine actually helped clear some of the plaques. But unfortunately, a number of people also ended up with encephalitis. Nobody died from it, but they got really sick. However, when they did the autopsy, once they died naturally or from other causes, they did see that the medication, the vaccine did what it was supposed to do. It cleared the plaques in the brain. The only problem is that we see also anecdotally that for people where medications have been able to clear the plaques, we actually have not been able to see any kind of clinical improvement once we clear the plaques in those cases. It works wonderfully in rats and mice, but unfortunately we're not rats or mice. So we found a cure for Alzheimer's disease in mice, but not for humans yet. So there's another type of immunization that's been developed now, and it's a medication that's used to develop antibodies towards the A beta or the plaque portion of the disease. But unfortunately, that one failed phase 2 trials, which is actually not that great because usually most of the prominent ones failed phase 3, which are the bigger trials. But nonetheless, using statistical mumbo jumbo and wizardry, they found a reason to kind of go on to phase 3 trials in a specific population of people with Alzheimer's disease. So it'd be interesting to see what happens, but I'm not quite sure how good that's going to be. We won't talk about the canine stuff. So other medications, intravenous immune globulins are being looked at. Other medications are used to basically prevent the production of the bad beta amyloid or the plaque compositions. But again, many of the kind of prominent ones that seem to do well in earlier studies, phase 2 trials, have failed miserably in the phase 3 trials, which are the more important, the bigger studies that not only look at efficacy, but also safety, but also look at efficacy as well. A number of them, like fluorazane, didn't pan out very well. The other one is this one, tramiprosate, which I think it went by another name. I think it was Alzheimer, which also did very well in phase 2 trials, but in the bigger phase 3 trials just failed. But the thing to be aware about Alzheimer or tramiprosate is because its component is kind of composed of certain amino acids. Some, I guess, nefarious nutraceutical companies have taken it and marketed it under as Vivamine. And we've actually seen people who come in with Vivamine. Vivamine is about $50 or $70 a bottle. And it's basically tramiprosate or Alzheimer. And this medication or nutraceutical has already been demonstrated not to be effective. So again, just to kind of FYI for people, if you've read Vivamine and you're thinking about getting it, maybe not such a great idea. There is another medication along the same lines of trying to decrease the rate at which the bad beta amyloid is produced. It's called PBT2, and it somehow affects copper and zinc in the cells. And somehow it's thought that copper and zinc somehow affects the cell's ability to form beta amyloid. So that's still in development. It's in phase 2 trials now. So I guess in the next year, a couple of years, we'll probably hear a little bit more about that, if it goes well. So this one, methylonium chloride, is basically for people who've done biology, is a form of methylene blue. So it's kind of a dye for cells when you look under a microscope. This is under the name of Rember, and somehow this medication inhibits not the plaque formation, but the tangles, the tau tangles in the brain. And again, it seemed to do good in phase 2 trials. The phase 3 trials are coming soon, probably. But kind of reading between the lines, there is some suspicion that the methodology of the science is a little bit circumspect. So again, time will tell. There was another medication called Dimibon, which is an antihistamine used in Russia for a number of years. It was felt that this medication in the Russian trials seemed to help with Alzheimer's or slowing down or treating Alzheimer's disease, but when it was moved into the international kind of forum, multi-centered, multi-year clinical trials, phase 3 trials, it also failed as well. There is more close to home. There were studies done regarding use of antibiotics. Again, for the sake of time, I'll let you read it for yourself. But 3-month course hardly would make one be very confident about this modality. I think more research is needed. And then the last couple of slides is to address some questions that have come up in the last couple of years regarding things that have been posted on the Alzheimer's chat rooms and so on and so forth. And one of the medications is etanercept or Embro, which is a rheumatoid arthritis medication. The indication is for rheumatoid arthritis, but there was a study that was published regarding using this medication in people with Alzheimer's disease, and how about after 8 minutes or something ridiculous time period that these persons' minimum mental state examination went from, increased dramatically. I have a problem with this, and certainly, that goes against how the pathology of disease works. And the other thing that's kind of concerning is that the person who actually published this data, who's the most prominent person who's driving this, is actually have stocks in the company that produces it. So I have a problem with that. Lately, Baxarotene, which is a medication that's been used for certain types of skin cancer, have been found that it also clears plaques in, I think, mice as well. Again, boy, mice have it good because they're getting all these medications that clears plaques and does well for them. But again, no clinical studies in terms of good randomized controlled trials in the scientific literature looking at specifically this medication in terms of treating people with Alzheimer's dementia. So again, until we hear more about and see more studies, I really wouldn't go with this at this point in time. And as I mentioned before, just because you clear the plaques in your brain doesn't always correlate to improvements in functioning. And then the one final thing was about virgin coconut oil, non-refined virgin coconut oil. Again, it was based on a physician who had good experience with her husband with it and did a lot of work studying it. And in conjunction with Dr. Bruce Fife, who's the director of Philippine Coconut Authority Governing Board, they kind of went forward and kind of published this data and kind of exposing the benefits of using coconut oil. But again, there's really no objective clinical research to support the use of coconut oil in people with Alzheimer's disease. And you also have to be careful that there are issues regarding saturated fatty acids in coconut oil that could be problematic for people who have cardiovascular disease. So again, health benefits, health risk, I think you have to decide. As well, certainly coconut water is high in potassium. Again, that is not particularly a great thing if you have heart conditions. So, buyer beware. So, we're at the end of our talk, and these are just some slides to kind of show you that Alzheimer's dementia or dementia really has no prejudice. It will affect a male, female, old, and people who are famous and not famous. So, people you may not know have had it are Norman Rockwell, Rita Hayworth. Estelle Getty actually had Lewy body dementia. She actually didn't have Alzheimer's, but I put her in there as well. Perry Como, James Doohan, or Scotty. We know this guy, Charlton Heston, Margaret Thatcher, Ronald Reagan. And I also found out recently that Charles Bronson actually had it. And one of the animators from the Hanna-Barbera cartoons, William Hanna, actually had it as well. And he's the guy, that's the team that made the Flintstones and all that stuff. So very many people have been affected by this disease. So anyway, I guess all of you are probably in the same condition as my two fellows here. So. Hopefully not as bad as Wellington over there.
Thank you, Dr. Lamb. That's great.